Everyone, thanks, Bertha. Thank you all for joining us this evening and spending your precious evening minutes with us. My name is Dr. Vanishri Anand. I'm a GP practicing in the heart of Southwest Sydney in the beautiful leafy suburb of Chipping Norton. Tonight's webinar is an initiative of the Health Professionals Network, whose mission is to disseminate health information to colleagues and community alike. This is the first of the talks on the management of COVID-19 run by us. We have an elite panel of speakers tonight who have been working tirelessly throughout the pandemic, offering their expertise across various healthcare sectors. COVID-19 has, of course, consumed a lot of our lives in the last 2 years. And throughout this time frame, we have been learning constantly. We've been learning new things and we've been applying that knowledge to the betterment of our communities. Our first speaker for tonight is Dr. Elaine Tennant, and I would like to welcome her. Dr. Tennant is an infectious diseases and public health physician. She is the director at Health Protection New South Wales Communicable Diseases Branch, where she manages non-COVID communicable diseases. She also holds appointments as an ID specialist at the Prince of Wales and Northern Beaches hospitals. She's worked on the COVID response teams as a member of the NBH COVID Clinical Advisory Panel, Royal North Shore Hospital. And she's an admitting COVID physician at the Prince of Wales Hospital. Please welcome Dr. Elaine Tennant.
Thank you very much for the opportunity to present. So I'm an infectious diseases physician from Prince of Wales Hospital and Northern Beaches Hospital. And I've been asked to speak a bit about the process for COVID positive patients once they find out they're positive. And that will involve outpatient clinical monitoring. And then I'll talk a little bit about some of the principles of contact tracing. So I'd like to also acknowledge the traditional custodians of the land on which we're meeting and pay my respects to elders past and present. Also a disclaimer, as we all are well aware, one of the most challenging aspects of this pandemic for healthcare workers and for human beings in general has been that it's been so rapidly moving. And some information that you might give to your colleagues one day is completely the opposite the next day and subject to change at short notice. As you're all aware, COVID-19 has a large spectrum of severity of presentations, and up to 30% can be symptomatic. I still get calls from junior medical officers who are trying to guess whether someone's symptoms could be or couldn't be COVID. But the fact is, having seen a bit of this disease over the pandemic, it really can be very difficult to know, and the presentations are myriad. So we have to maintain a higher index of suspicion all the time. 80% will have mild to moderate disease, and most of them will recover within less than 2 weeks after onset. However, 15% of them will develop severe disease and 5% critical. Importantly, from an infection control perspective, the incubation period is up to 14 days, though most cases occur to 4 to 5 days post-exposure. And there's a very, very small incidence where the incubation period can be longer than 14 days, but that's rare. People are infectious for 48 hours due to symptom onset, and there are a variety of symptoms that people can present with, so upper and lower respiratory tract symptoms, loss of taste or smell are the kind of most common symptoms, but particularly with the Delta variant, we're seeing a higher incidence of patients that are complaining of headache and myalgia, and also patients presenting with gastrointestinal symptoms. So the case fatality globally is 2%, and we're doing a little bit better in Australia, where it's 1.2%. In terms of risk factors for acquisition and severe disease, the tables that are outlined here are from the New South Wales Health COVID-19 surveillance report, and these are produced weekly. I've put a link later on in my slides, and they really are a wealth of information because they provide some epidemiological information about which areas are affected and whether the cases are going up and down. So the take-home points from this slide are that 87% of locally acquired cases to date during this current outbreak have been unvaccinated, compared with only 2.6 that were fully vaccinated. The hospitalization risk generally increases with age. There are certain comorbidities that are associated with severe illness. So obesity, diabetes, and respiratory and cardiac complications, as well as a background of malignancy. And then there are also some demographic factors. Sadly, we're seeing some poor outcomes in Pacific Islander communities, particularly. And in terms of infection rates, we're certainly seeing more people in marginalized communities, such as people who use drugs and homeless communities. So that's really important to look out for. Severity assessment will be covered in a later talk, but just to say, most patients with COVID won't have blood tests, but if we think that they've got more than mild disease, we will do some blood tests. And I've listed some of the markers that have been found through research to be severe prognostic markers. So what's the procedure when a patient turns positive with COVID? So there's a central portal that the labs upload results to that is held by the ministry. And after the results are uploaded to a portal, there is allocation basically into two parallel processes. So one of those processes is the public health management of the COVID patient, and that is undertaken by the local public health unit, depending on where they live. And then parallel to that, there's allocation to a community team to perform monitoring in the community. And I'll talk about that a little bit more. And those are LHD based as well. I understand that most of the people dialing in from here are working in Eastern and Central Sydney. The systems are a little bit different in different areas, and I'm going to be talking about the Southeast Sydney LHD community COVID team because that's the one that I'm most familiar with. But the model of care is basically the same or similar in different areas. And so the patient will be contacted by the clinical team that are responsible for monitoring to get them linked up to that community clinical monitoring team. And in terms of public health follow-up, depending on the burden of cases, they may or may not get interviewed for follow-up. So at the moment, what happens is that the patient gets an SMS notification from the public health authorities, and that links to a questionnaire that they then fill in. And the questionnaire seeks to look out for potential high-risk exposures so that they can triage people that they really need to interview earlier rather than later. As well as that, the laboratory themselves may notify the patient that they are positive. So they may get communication from multiple areas of the health service. So I'll just talk a little bit about the COVID community team at Southeast Sydney Local Health District. And I want to say thanks to Dr. Kristen Overton, who's the clinical lead of that service at Prince of Wales, for provision of some of these slides. So the goal is basically to keep people safe while they're isolating at home, to try and identify those who might need to move to hospital early, and then also to deal with any non-COVID medical and social issues that might arise during the home isolation period. So home monitoring consists of a patient being delivered a SATS probe, and depending on the service that are doing the monitoring, there'll be either phone calls or an app, or a combination of the two. In the model of care in Southeast Sydney, the app is the preferred method. And so the patient answers a questionnaire daily. I've given some screenshots here. And they also monitor their heart rate and oxygen levels and enter those twice daily into the app. And then the clinical team are alerted if there's any concerns in any of that information entered, and follow up with a phone call. There's also a button on the app that says, "I'm feeling worse," that patients can push, and someone will call them within 30 minutes. The service is staffed between 8 a.m. and 8 p.m. And after hours or in an emergency, patients are advised to call 000 and obviously tell them that they have COVID so that appropriate precautions can be used. And then the app has an interactive and supportive patient interface so they can review their own saturation and pulse readings, as well as automated notifications to the patient to remind them that they need to look at their SATs levels and complete the questionnaire. It's translated into 6 languages. And then there's a facility for telehealth, as many of our health services have, to assess patients and figure out whether they can still be managed at home or whether they might need to be admitted to hospital. So the things that we're really looking for in detail is how dyspneic they are, what's happening with their fevers, what their kind of progression is over time and whether they're deteriorating. And then some red flag symptoms, such as are they having significant gastrointestinal symptoms, fainting or chest pain. So there are algorithms that are used by the clinical team to try and risk assess people and decide where they should be managed and whether they should receive a phone call from a nurse, a doctor, or be sent to hospital. And that depends on some of the risk factors that I talked about before. In terms of underlying risk factors, there are social risk factors that are considered, age is considered, and of course what the patient is telling the team is happening. So I thought I'd just talk very briefly about some principles of contact tracing. Some of this might be very familiar. So unfortunately, one of the perhaps more painful parts of the COVID pandemic is, that we're often having to deal with multiple incursions of COVID into healthcare facilities, and then make sure that we're promptly contact tracing and isolating people and testing, so that we try and lock those down. So currently, the close contact is required to isolate for 14 days since their last contact with someone with COVID-19 and have a test immediately, and then again at day 10 and 14, and there's a fact sheet online. And in terms of household close contacts, that's sometimes occurs when we've got healthcare workers that either are positive or that one of their relatives is positive, so we need to counsel people about that. So household close contacts are required to isolate at home, and that means isolate from each other as well. So we say that people need to either have an ensuite bathroom and be able to be delivered food, or they have to live in a granny flat. So we have to be quite confident that they are able to effectively isolate. And if there's a household that is affected, so we know that there are high rates of transmission amongst households. Basically, everyone that is not yet positive is considered a close contact, and they have to isolate for 14 days after the last positive test of a household member. And if another household member becomes positive, then that 14-day clock restarts. And then casual contacts currently have to self-isolate until they've received a negative result. Low-risk contacts just need to monitor for symptoms. So in terms of managing healthcare exposures, you'll probably all be aware that there is a CEC matrix. I've just given a copy here of the CDNA song. So this is the national guideline for management of COVID. And in their recent iteration, which came out yesterday, they have they've put in a table for management of healthcare exposures. It's a bit similar to the one that we've been using in New South Wales. However, they've now accounted for whether people are vaccinated or unvaccinated. And that's made the risk assessment a little bit less conservative and quite helpful. So I think the take-home points from this are that if you're wearing a mask, but also eye protection, so not glasses, but dedicated face shield or goggles, then that reduces the risk of transmission. And therefore, if your staff are wearing eye protection, it reduces the chance of them having to take time off work. There are also some changes in this particular guideline, whereby high-risk contacts might, depending on the risk assessment, be able to return to work at day 5 if they have a negative test, but with increased surveillance requirements. And that's a bit of a change from what we have been doing, which is making people isolate for 14 days after a close contact. So there will be a New South Wales version of this coming out, probably based on the same principles. And the ministry are also working on a community risk assessment matrix for GP practices. That will look at healthcare contacts, but it will also address non-healthcare contacts. So patients, for instance, that are exposed in the waiting room, and whether you would classify them as close or casual contacts. And some of the factors taken into consideration would include the size of the outdoor space, duration of the contact, mask wearing, and vaccination status. Just going to flick back to this slide. So in terms of the clinical team monitoring, one of their jobs is also to provide release from isolation for cases. So that's determined by the managing team, and the patient will be supplied with a letter to say that they have been cleared from COVID. In terms of isolation criteria, so again, these are based on the CDNA SONG guidelines, which are updated very, very frequently. In summary, if a patient's asymptomatic with COVID, then they can generally be released after 14 days. Even if they've been symptomatic, but they've had substantial improvement after 14 days in the last 72 hours, then they can also be released. Or if they have ongoing symptoms, pretty much everyone can be released after 20 days. The exception is for immunocompromised patients who we know shed sometimes viable virus for much longer. And so often those cases are discussed amongst an expert panel to make a determination. There is a practice in some hospitals of doing viral cultures as well. If you swab people who have had COVID for prolonged periods of time, they often will stay positive for some time, but that doesn't necessarily represent viable virus. So I'm just about ready to wrap up, but in terms of actions for all healthcare workers, I think everybody, all of us that work in hospital are incredibly grateful to the GP community for all the work that you've done on getting people vaccinated. You know, it's really awful seeing these patients that are sick with COVID in hospital, particularly when whole families are affected and not all of them make it out of hospital. We can really see the impact of vaccination, and you know, all healthcare workers need to be talking to their patients about vaccination and encouraging it, and addressing, you know, understandable concerns about side effects as well. We need to, as we open up, encourage social distancing, mask wearing and hand hygiene, and keep encouraging patients to get tested if they're sick, emphasizing that COVID can mimic other conditions and you can't tell just by your symptoms clearly whether you've got COVID or not. If you're thinking of treating anybody for pneumonia, please do a COVID test, and also consider COVID tests on patients presenting with headache and GI symptoms, given the Delta variant propensity to cause those symptoms. And finally, I think as things open up, people move more and the borders reopen, we're going to need to shift our thinking, as well as keeping our eye on the ball with COVID, but also thinking about non-COVID infections. So anyone with a chronic cough could have TB. We've had the highest TB rates for a long time in New South Wales this year. So please organise sputum testing and a chest X-ray. Lots of patients will be desperate to get overseas to visit friends and relatives. So please consider talking to them about measles, Hep A and typhoid, for instance. And we may well get a bad flu season going forward because we haven't had a lot of flu around, you know, in the last couple of years. So I'll wrap it up there. Thanks.
Thank you. Thank you so much, Elaine. That was amazing. There are already lots of questions pouring in. I don't know if we shall wait towards the end to bunch all the questions together, but there's lots of questions already coming through. So moving on to our next speaker, we have Dr. Guruprasad Nagaraj, who is from the emergency department side of things. He's a senior emergency physician with a special interest in acute care of elderly, integrated care, and end-of-life care. He's a conjoint lecturer at University of New South Wales and a senior research fellow at Southwestern Emergency Research Institute. He also works with many boards in various capacities. So welcome, Dr. Guruprasad.
Thanks, Guru. I'm as ED physician at Liverpool ED. So we've been the epicenter for COVID, especially during the second wave. So I'm just going to go through a few details around what happens in ED and what we are seeing and what's going on. So essentially, interestingly, the caseload in ED has significantly decreased from year before. So like up to 25% decrease in ED activity. And like in a presentation in all triage categories went down except for category 1. And partly this might be because most of the COVID patients, if they're sick, they are very, very sick. And as soon as they present with significant respiratory, they are all given a Cat 1. So that might be the thing. And as mentioned earlier, like the number of presentations with infectious disease, enteric diseases, pneumonia, fractures, stroke, intracerebral hemorrhage, and chest pain also have come down. The reason for this, we are not absolutely sure. The infectious diseases is probably because people are not in touch with each other. They are not sort of meeting it. But rest of the things, we are not entirely sure. There are various sort of thought processes behind that, but we are not sure. So so I was just, this is some data from ED over last 2 months. So in August, we saw around 6,100 patients. And out of that, around 1,000 patients were COVID positive. So around 18% were COVID presentations. And out of those, 66 were admitted in August, and 27 were discharged, and 72 were transferred to other hospitals. In September, so the total presentations were sort of similar, but the number of COVID presentations increased. But interestingly, the admission rate came down to around 46%. And then we were discharging more patients than compared to August. And the COVID transferred increased sort of almost doubled in September. This probably is because in August, almost at the end of August, last week or 10 days, we had significant increase in number of presentations and admissions. So that meant we could not treat all these patients at Liverpool and we had to transfer them out. So just a quick chat about the pediatric presentations to ED. So 30% of presentations with COVID, the first presentation was to emergency departments, and 22% of them did not have any signs or symptoms at time of presentation. And the ones who did have, the commonest presentation was fever, stuffy nose, and cough. And there were other sort of presenting symptoms like sore throat, headache, difficulty in breathing, muscle ache, diarrhea, and anosmia. So essentially there were 131 patients who presented, and then 115 or 88% of them did not need any intervention in ED. So only 12% we had to be involved and sort of provide some sort of treatment. And when we did, it was antibiotics and fluids most of the time, and steroids. So I don't want to go too much into too much detail around mental health, but during 2020, the psychological distress went up and the presentations went up, but in 2021, it sort of came back to its normal rates. But however, in younger patients, we were seeing more younger patients presenting to ED with psychological distress. So how did we, I'll go back to the slide. So how do the patients present to ED? Either they walk in or they come via own transport, or we diagnose them in ED. So all these things have impact, because if they walk in and we don't know anything about, we are putting the whole system at risk. So this is something we are always vigilant about. And it's not that like it has not happened, it has happened, and we have seen this happen. So if there is anyone out there whom you're worried about, or like, when you're telling the patients, the best thing is to sort of call an ambulance, or like, or let us know earlier so that we can wash out. The other thing is own transport. So like we have seen patients, despite being told you can't get out of the house, you have to isolate, present in their own car. And especially like we have seen patients who've brought their loved ones to the hospital, not realizing probably that's not the best thing to do. And then ambulances, usually the sick ones come through ambulances. We usually get a forward notification, and sort of gives us some time to prepare. And the rest of them are diagnosed in ED. We have had patients who have come in with leg pain and like completely unrelated symptoms, whom we have swabbed them, they have come back positive. So we have seen different variety of presentations. So how did we adapt to these? So at this stage, especially with the second wave, when we are on the floor, we all have to wear N95 masks and splash-proof goggles all through the shift. So like, if you're on the floor for 10 hours, all 10 hours, you have to wear those. And if you're going closer to the patients, we wear PPEs as required, where if you are intubation, the PPE level goes up. Otherwise, like you wear a gown and then shoe covers and relevant stuff. So in our emergency department, there are different areas. So at one stage, so we have a 7-bed area, there's 11-bed area, and then sort of also there is a 4-bedded area within the acute section, wherein like we, at one stage at the peak, we had to use all of those beds. And also we have other areas where we put possible or suspected COVID patients. So there are usually 4 beds. Sometimes we increase it to 4 extra beds. And then there are general areas. And there are 2 separate beds where we put immunocompromised patients, or people whom we are really worried about, whom we suspect they might have COVID, but like they are not come for COVID, because the last thing you want is to give expose them to COVID. So, and then like when the patients come in, they all are expected to wear masks and face shields if they are high risk, or if they are in the COVID area. Otherwise, they are expected to wear masks. So hospital-wise, what have we done? We have sort of have separate areas. There are separate COVID wards and areas, and they have been fitted up appropriately, and there are special staff which are allocated to these areas. We have modified the ways of admission pathways. So many a times, even like pregnant women with a bit of shortness of breath or cough, like we usually try and admit them. And usually they used to go to a birthing unit or the obstetric area, but like these days they might go into the COVID ward and be looked after by obs-gynae. And then lots of like non-emergency work has been cancelled. COVID buses, this is something which is sort of we had to come up with, because we had got all these patients who were coming in by their own transport or dropped off by ambulance, but we could not get them back because of the restrictions. So and often patients were waiting in emergency department for 8-12 hours to get transport back. So that's one of the things that the hospitals have started. And we all know about the quarantine hospitals, and Elaine did talk about remote monitoring. And also, like, we've been in discussions with residential aged care facilities and modified the pathways through them. So other issues, we have inter-hospital transfers for COVID and non-COVID have increased. But having said that, given there few of the LGAs are under lockdown, there has been significant issue transferring patients between different LGAs, which meant that few of the sicker patients were stuck in the rural areas or the smaller EDs elsewhere, and we could not bring them to the major centers, which has caused significant issues. And there has been sort of aggression towards the staff because the carers can't come in, or we have limited a number of people who can come in. And especially in places where we have called patients, it's a bigger issue. And though the presentations have come down, the work pressure hasn't gone down for ED, and lots of them are going through emotional stress, because often when you see them, it's not just the patient. And we had pregnant ladies come in with COVID, and the level of anxiety goes with that. And also you're anxious when you're intubating these patients or providing high flow, you might be exposing yourself or your colleagues. So I instituted well-being days and several well-being programs and buddy programs, mentoring and stuff, so which is sort of helping. But interestingly, over the last few weeks, what I have noticed is that the mood is a bit better than what it has been, and people are a bit more comfortable with dealing with the issues. I'm not going to go much to this. Many of these things have been discussed. So we did talk about the risk, the symptoms. So essentially it's either respiratory symptoms or gastrointestinal symptoms, and chest pain and sometimes hemoptysis are the things that worry us. I'll share the slides, so it's all there, and Elaine did talk about a few of these things. But what we worried is severe GI symptoms, hypotension, syncope, chest pains, silent hypoxia. This is one of the biggest issues. Many people present who are hypoxic, significantly hypoxic, might not have any symptoms, which might mean that they are presenting quite late and end up needing more therapy than what they would have, or maybe we could have helped them better if they had presented earlier. We did talk about it. So this will be discussed again, mild, moderate, so I'm not going to go there. Yeah, I think. Yeah, and then what's happening with many of these patients, the mild ones usually go home if they don't need oxygen requirement, and everyone else gets admitted. And usually we talk to the ICU if they are sick early. So in summary, ED presentations have come down, but the workload has not. And the other thing is, we are much worried about the patients we are as much worried about the patients who are coming to ED as we are worried about the ones who are not presenting to ED, because we are there are still people having chest pains, and they might be having non-STEMI strokes or TIAs, but they're very worried coming into the ED, and then we don't know the whole picture, and then complicate the non-COVID complications of COVID at this stage. If you're worried about anyone, please do send them. And if the patient is complex, especially if they are immunocompromised or any other issues, we would always welcome a call so that we can prepare for that. Thank you.
Thank you so much, Dr. Gurprasad. That was very useful. As you might look into the Q&A box, there's already lots of questions pouring in. If you're able to take your time and just answer some of them in the chat box itself, in the Q&A box itself, that would be great. Thank you very much. Our next speaker is Dr. Shakthi Dabholkar, and he's got his camera on. So welcome, Shakthi. And he's literally joining us from the front line, still in his scrub. So he's coming straight from his shift on the COVID ward. Thank you so much. Dr. Shakthi is a respiratory final year advanced trainee. He's currently working at Liverpool Hospital. And in the last few months, 3 to 4 months, he's been right at the forefront of the current pandemic. And Southwest Sydney has, as you all know, had a pretty bad hit during this outbreak. He has admitted and looked after, and I'm sure still looking after, more than 100 to 120 COVID patients. So over to you, Shakthi.
For joining this talk about COVID-19. My topic is about treatment for mild, moderate, and severe COVID-19 disease. Before we talk about treatment, I thought just spend just one slide talking about definitions of severity. And the key thing to talk about is that COVID-19 is defined as either mild, moderate, severe, or critical disease. And there's unfortunately variations in definitions for each of the groups. But just to sort of summarize and keep it very simple, mild disease incorporates people who are not requiring supplemental oxygen and are not hypoxemic. And usually these patients present with mild upper respiratory tract type infection symptoms, including cough, myalgias. Moderate disease is where we start to see hypoxemia. And definitions vary slightly, but it's essentially moderate is defined as requiring supplemental oxygen up to about 4 liters per minute by low flow nasal prongs, maintaining saturations of 92% or above. And these patients generally appear much sicker, generally have severe cough or persistent cough, usually very lethargic, and there's usual signs and symptoms of a viral pneumonia, including crackles that you can auscultate on the chest, as well as a bilateral infiltrate on chest X-ray. Severe disease is where they're significantly hypoxic, significantly tachypneic, with a respiratory rate usually above 30, as per some definitions. And critical disease is where we start to use, advanced forms of oxygen delivery, including high flow nasal prongs, CPAP, NIV, as well as patients that are intubated in ICU. And often associated with other evidence of end organ disease. Majority of our COVID-19 patients, about 80%, only have the mild form of disease. And these are patients that I don't really get to see because they're mainly managed in the community. It's really the moderate and severe forms, which represent about 15% of COVID-19, and certainly the critical forms, which represent about 5% that are managed in a hospital setting. This slide here looks at, again, mild, moderate, and severe. And the key thing that I want to point out about this slide is that first of all, COVID can be split into 2 phases. The first phase is the viral replication phase. And this is usually in the first 5 days of symptoms, of symptom onset, where we consider day 0 to be the start of COVID symptoms. And it's usually in the second week, from about day 5 to 10 days onwards, that patients, if they are going to deteriorate. And this is where we generally tend to see patients being admitted. Now, this slide, I hope it's not interrupted from the Zoom controls, but basically this slide is taken from a nice review article from NEJM, which looks at mild and moderate disease. So if you'd like to see this article, there's a QR code on the slide, so you could just use your cameras to scan that, and it'll take you straight to the article. And there's several of these on my talk, which you can access just from scanning the QR code on the top right. So what's the mainstay of treatment for mild COVID disease? Well, first of all, it's isolation, either in the home environment, if it's suitable, or in certain community facilities like Medi-hotels. The main treatment for mild disease, because they're not hypoxemic, is just symptomatic treatment with antipyretics such as paracetamol or ibuprofen. Adequate oral hydration is also very important, and maintaining a normal nutrition. And really, it's during this phase of illness that we're really monitoring for deterioration. So if they start getting dyspneic, particularly at rest, if they get other symptoms like chest pain, or they're not maintaining an oral intake, that's when we start to sort of need to refer these patients to hospital for ongoing management. We have a system here where community nurses follow up patients in the community, and patients usually get called every day. Some patients are given a pulse oximeter, and we monitor their saturations. And if there's any sign of desaturation from baseline, it's usually when we send them to hospital. And I thought I'd mention some disease-modifying therapies that are showing emerging evidence in mild COVID-19. I'll talk a little bit about these in the next couple of slides. But what we do know is that the studies have shown there's no evidence for systemic steroids, and that's based on a large trial, which I'll talk about. There's no evidence for antibiotics and a couple of the other medicines that have been circulating on perhaps social media, such as hydroxychloroquine, ivermectin, and zinc. The only reason that we use ivermectin in hospital is if they've got a positive strongyloides serology and they're on a disease-modifying therapy such as baricitinib and Tosylusimab. We only give them a course that we usually treat to treat strongyloides. So this is a very new trial that's come up. That's looked at inhaled budesonide of all things, which is very obviously very well prescribed for asthma. And the two trials that have recently come out this year is the Stoic Trial and the Principal Trial, which the latter of which I'll talk about in more detail. Again, if you'd like to see details of the Principal Trial, just scan the QR code and it will take you straight to the source on Nejm. So this was an open label randomized control trial that looked at inhaled Pulmicort at a dose of 800 micrograms twice daily for only 14 days for patients with mild COVID disease that were not hypoxemic. There were certain limitations to this. It was not a placebo-controlled trial, and it was not blinded. So there's some of the sort of fallbacks of this specific trial. But what it showed is that there was a statistically significant reduction in time to recovery, which was measured by patient symptoms. And also, interestingly, showed a reduced rates of hospital admission or death at 28 days. And this was statistically significant, and it was a relative risk reduction of 27%. So the current COVID-19 National Task Force has released guidelines, and these have suggested, this has just recently come out regarding inhaled Pulmicort, and they've suggested to consider inhaled budesonide 800 micrograms, that's the 400 turbohaler, 2 puffs twice daily, for up to 14 days in adults who do not require supplemental oxygen and have the following risk factors. So they've got to be at least 65 years of age or above, or they've got to be 50 years of age and above with comorbidities. The other disease-modifying medication that we sometimes use is a medication called Cetravamab. Now, this is essentially a monoclonal antibody that binds to SARS-CoV-2. And it basically acts like giving someone the antibodies from an injection, like from a vaccination. So it's a monoclonal antibody that works by binding to the SARS-CoV-2 and prevents, was designed to prevent further replication and spread of the virus in the body. So this is based on a trial known as the Comet Ice trial. Again, you can access this from the QR code. This is a phase 3 multi-center randomized and double-blind study that was placebo-controlled. The only caveat for this is that the paper that's been released has not been peer-reviewed yet, so it still hasn't been formally published in a journal. It's a preprint. And this looked at about 500 patients that were randomized to either placebo or one stat dose of IV Cetravamab, 500 milligrams. And the main endpoint of this study was a composite of patients requiring hospital admission for more than 24 hours or death. And what this study showed is that there was an 85% relative risk reduction from either death or hospitalization requiring more than 24 hours. There were similar rates of side effects, the main ones being diarrhea which I guess in practice is very hard to differentiate from diarrhea related to COVID. So I'm not sure exactly how they looked at that. The COVID-19 National Task Force has made a conditional recommendation to consider using Cetravamab for treatment of COVID-19 for patients within 5 days of symptom onset. So it's very early in their disease course, who do not require oxygen and have other risk factors. There's a whole list of that, of risk factors. And the main ones are people with chronic lung disease, kidney disease, liver disease, patients that have not been vaccinated, or that have been vaccinated but have evidence of immunosuppression. So for example, patients that are on DMARDs for rheumatoid arthritis, or other forms of immunosuppression such as chemotherapy for malignancies. Very briefly on moderate and severe COVID-19, well, these are the patients that we generally see in hospital. We treat them with supplemental oxygen from various forms, from low flow all the way up to high flow, CPAP, and bi-level positive airway pressure. We use a lot of prone positioning in our hospital patients who need oxygen. And what this does is it basically redistributes the blood flow based upon gravity and improves VQ mismatch. And it actually works really well. And we find that patients that are prone tend to oxygenate a lot better. DVT prophylaxis is really important because we know that COVID-19 is a prothrombotic disease. So it's really quite important to make sure that they're on appropriate DVT prophylaxis. And we generally avoid broad spectrum antibiotics. And there was a study done in the Chest Journal which showed that patients that were given broad spectrum antibiotics on admission tended to have higher rates of bacterial sepsis with resistant organisms, or hospital sepsis with resistant organisms. So we're very judicious with our use of antibiotics. There are various disease-modifying therapies we use in moderate to severe disease. So these are patients that are hypoxic and need supplemental oxygen, at least. The main ones are dexamethasone, which we give for 10 days. Remdesivir is an antiviral. There's mixed evidence for this, but it is conditionally approved. It's an IV antiviral. It works a bit like Tamiflu in that it's the best, I guess, evidence is in the early stages of disease. There are two trials. Neither of them show a mortality benefit, and only the ACT-2 trial, ACT-1 trial showed a faster recovery from hospital admission by about 4 days. So we do tend to use this at times. Baricitinib is a JAK2 inhibitor, and basically it's an immunosuppressant anti-inflammatory. Before COVID, it was actually used in rheumatoid arthritis. But with COVID, there is evidence for use, so 4 milligrams for only 2 weeks. And it's shown to have mortality benefit in patients who need high flow nasal prong oxygen or high levels of oxygen therapy, so really the severe to critical disease. So we do tend to use this a lot. And there's also IV Tosylusimab, and this is an IL-6 inhibitor, and IL-6 is an inflammatory cytokine that we know cause significant pneumonitis in COVID patients. And again, this is based on the Recovery trial, which is a large platform study, and this has shown mortality benefits in patients with severe and critical disease. The problem with IV Tosylusimab that we're having at the moment is there's a lack of supply. But we're finding that baricitinib, which also inhibits IL-6 as well as other interleukins and inflammatory mediators, we're tending to use that mainly because of a supply supply problem. I just point you to the main trial, which is the Recovery trial, and this is the data that looks at dexamethasone, and this showed a mortality benefit by 36% in mechanically ventilated patients. And also a mortality benefit by 18% in patients requiring supplemental oxygen. So this is really our mainstay for disease-modifying therapy in COVID. The main thing to point out, as you can see, is that for patients that did not require oxygen, there was actually no benefit. And in fact, the study showed that there were increased risk of side effects. In critical disease, really these patients are managed in our intensive care unit. And they require very high levels of ventilatory and oxygenation support, such as from NIV to mechanical intubation. It's really important to manage comorbidities. And for young patients who are quite unwell and persistently hypoxemic despite intubation, there's also consideration for ECMO therapy, which is the extracorporeal membrane oxygenation. It's really when they come to hospital that we need to have really difficult conversations about ceilings of care. And we usually tend to have that early, particularly in our older patients. This is a patient who's got a lot of complications, as you can see. He's got bilateral pulmonary infiltrates, extensive bilateral infiltrates, which is common in our severe and critical COVID-19 pneumonitis patients. He's also got a lot of subcutaneous emphysema, and we're finding that there are higher rates of not just pneumothoraces, but pneumomediastinums in patients with COVID, possibly related to the disease, but also related to the therapies that we sometimes give, including positive pressure ventilation. Just a quick slide about beyond the acute illness. There are certain things that we consider as patients are being recovered. The main one being physical deconditioning. Some patients are in our acute wards for many weeks, and certainly those who've been in ICU for many weeks have significant deconditioning and need rehab afterwards. Venous thromboembolic disease is something that we're seeing more of, particularly in our patients that re-present after being discharged, usually at sort of day 20 plus. And they come in with worsening breathlessness. And when we do a CT-PA, we find that they've got pulmonary embolisms. We're also finding lots of rates of organizing pneumonia and post-infectious fibrosis. And this is despite a course of dexamethasone and even baricitinib. There's not a lot of evidence that supports therapy in these patients. And depending on, I guess, their clinical status, oxygen requirement, and radiology, we're sometimes giving them just a course of steroids, which we're sort of using empirically with not a lot of evidence in an effort to inhibit the inflammatory process and hopefully inhibit long-term scarring. But there's not a lot of evidence in this. This is mainly an evidence-free zone. The scan on the left here is a patient, a young 20-odd-year-old lady who actually had COVID-19 and was managed in the community. She only had mild disease, was never hypoxic as far as we are aware of, albeit she didn't have a pulse oximeter at home. And she was actually de-isolated in the community and then subsequently presented with just persistent breathlessness. And this is a slice of her CT-PA, which showed extensive fibrosis. And there's also a lot of volume loss on the left side. What's not shown here on the CT is that she actually had a PE as well. So she had both complications and was treated with therapeutic anticoagulation. Then there's this issue of release of isolation. There are a set of complex rules, but basically in the community, if you're 14 days past your initial symptom, you're generally deemed de-isolated, although there's probably fine prints, and I'm sure there are various documentations that look at this. If you're in hospital, you usually need to be 21 days post symptoms. But there's certain caveats, such as being immunosuppressed, and there's certain rules that we follow. And we have a clearance committee in hospital that go through all the different cases and look at all their different comorbidities and start times of their illness. And we make a very clear decision of when they can be de-isolated. When they're de-isolated, we don't generally re-swab them. And the reason for this is that COVID patients can have persistently positive PCR for several months down the track. So it can actually be a false positive result, particularly when they've had an acute illness and have convalesced and improved. We do, however, recommend re-swabbing patients down the track who have gotten a recurrence of symptoms consistent with COVID. And the last point is vaccination post-COVID-19. We don't have any set guidelines or policies, but we generally recommend that patients who've suffered through acute COVID-19 and have not been vaccinated to get their 2 doses of appropriate vaccines within 6 months, and usually about a month after they've been discharged or improved from their acute illness. So the take-home messages from this talk is that firstly, timing is everything. You really look at, really try and pinpoint when patients first became symptomatic, because that's really everything for us, as it sort of dictates what sort of therapies, and particularly disease-modifying therapies, that we can offer. Systemic steroids are only really have evidence in patients that are hypoxic. And there's new evidence for therapies like inhaled budesonide and Cetravamab, and our current guidelines have stated that you can consider these for use based upon the clinical picture. So thank you very much for listening. I just put 2 resources there. The first one is the National COVID-19 Clinical Evidence Task Force Guidelines, which are easily accessible for everyone and talk about pretty much everything that I've talked about here. They're very sort of easy to navigate, but just a word of caution that although these are meant to be updated very regularly, there are certain discrepancies at times. So always take the evidence that you read with a pinch of salt, and review the literature and I guess make your own sort of decision. The NSW Therapeutic Advisory Group is a second resource, and that's got patient information leaflets of all the disease-modifying therapies that we use, as well as guidelines regarding supply of these medicines.
Thank you so much, Shakthi. That was very comprehensive as well as very informative. Thank you very much. We hope you finish your shift soon and go home and get some rest today. Thanks for that. Our next speaker is lucky last, Dr. Kishore. So Dr. Kishore Kardapo is the director of the Cardiac Diagnostic Unit at Campbelltown Hospital. He's a senior staff specialist and interventional cardiologist at Liverpool and Campbelltown Hospitals. He's also the co-chair of the Sydney Cardiac Clinical Academic Group and a senior lecturer at Western Sydney Uni, and he's involved with both under and postgraduate training. He has a keen interest in cardiac function and chronic kidney disease and has acquired a PhD in the same subject. Currently, he's involved in research involving the effect of the COVID pandemic in cardiovascular services at the Southwest Sydney district. Welcome, Dr. Kishore, and over to you.
For the opportunity for both the HPN as well as the Central and Eastern Primary Health Network for regarding the cardiac complication in the COVID. As Elaine mentioned, Shakthi mentioned, this is very nascent disease, and every day we are getting new information, new changes, and this is very infant disease. So most of the information we have at the moment are from overseas, and we do see some patients who present to us with the cardiac complication. Even though numbers are less, we do see these complications. So basically, we should look into the what COVID causes into the heart or myocardial injury. And we don't know in the general population how many patients will have mild myocardial injury because they may be asymptomatic. But in hospitalized patients, we see up to 40 to 50% of patients have evidence of myocardial injury by elevation of the cardiac biomarker, either troponin or the BNP. And the main thing we see is the myocarditis, where the inflammation of the heart muscle, I will come to it a little later. And it may be because of high inflammation, which causes the oxygen supply and demand mismatch, gives a lot of stress on the heart and the stress myocardium. This also leads into the prothrombotic state, as Shakthi mentioned, which can cause the instability of the atherosclerotic plaque in the coronary end up with the acute myocardial infarction and non-STEMIs, and as well as the STEMI which we see nowadays. Sometimes there will be fibrin-rich microthrombi which will cause us the small vessel ischemia and may end up with the cardiomyopathy. Or it is just a stress myocardium causes the Takotsubo. We do see Takotsubo cardiomyopathy in the COVID infection. So this will give you a nutshell where COVID causes the myocardial or heart involvement. And the first thing is the direct entry of the COVID virus or a coronavirus, SARS-CoV-2 virus, which will enter into the myocardium using the ACE2 receptors. And that is why this is a multi-system disease, because you can see ACE2 receptor in heart, lungs, kidneys, blood vessels, everywhere. So wherever these receptors are there, the coronavirus will act upon that, and there will be hyper-regulation of the ACE system, which will causes the inflammation, and which will release the cytokines, and there will be a cytokine storm. That is why we use the immunosuppressives or Baricitinib or Tosylusimab to prevent this cytokine storm. With this, so either myocardium will get involved because of the direct invasion of the virus into the heart muscle, which causes the inflammation, or it can be because of the cytokine storm, and it may lead into the either myocarditis, or it may cause arrhythmias, either tachyarrhythmias or a bradyarrhythmia, where you may have AV conduction delays, or they may go into the persistent tachycardia. They may have the ventricular tachycardia or ventricular fibrillation, which will be life-threatening. Or it can cause the acute coronary syndrome. And you can see there is a plaque instability, which can cause the acute coronary syndrome. And finally, myocarditis. Few of the myocarditis may proceed into the cardiomyopathy, which is a long-term sequelae of this. So to see or say COVID has any heart involvement, we need a high suspicion, because the spectrum starts from asymptomatic individual into the fulminant cardiac failure. So we should have a high clinical suspicion to have a diagnosis of myocarditis. Then for the primary healthcare physicians, they should know about the basic investigation. And next two things, probably this patient will be end up in the hospital, mainly the hospital related treatment, like for the what you can do for the acute cardiac injury or treat myocarditis. But the last one, you will again left with these patients in the community who will have chronic cardiac sequelae, which we are still not much sure, because this, as I mentioned, this is a very nascent or infantile disease. We have a knowledge only less than 2 years. So this is a very infant, still in the infantile stage. So how they will present? They may present to you with just a fatigue. They may be having a dyspnea. They may have chest pain. That is when, if a person presents you with the dyspnea and chest pain, if they are COVID positive, it may be because of the involvement of the heart. Either it may be a myocarditis, it may be pericarditis, or it may be acute coronary syndrome. And sometimes they may present you with the syncope. Again, it may be because of brady or tachyarrhythmias. And obviously, in the final stage, they may have a fulminant heart failure features, either right or left, like elevated JVP, peripheral edema, or they will be in the acute pulmonary edema or a cardiogenic shock. So in this situation, they usually will be present into the emergency or a hospital. So if a person comes to you, how you will proceed to say whether they have a myocarditis or whether they have involvement of the heart. So you may be able to do some inflammatory markers like C-reactive protein or ESR. Troponin, usually I defer the primary care physicians to do, because when you do the troponin, it may come back after a few hours. You may miss the boat basically. And of course, if you have a istat troponin, that will be a good way to find whether there is a injury to the myocardium or elevation of the troponin. And BNP is helpful. The most important, if your surgery has ECG facility, you should get ECG with each and every patient who will present with the history of dyspnea or chest pain or syncope, because you can diagnose whether they have any AV conduction delay or whether they have a sinus tachycardia. See, the always my professor used to tell most scariest rhythm in the CCU or ICU is sinus tachycardia. We all think ventricular fibrillation is probably the scariest, but you know what to do with the ventricular fibrillation. You will cardiovert them. But the sinus tachycardia, there are many differential diagnoses, so you may not know what you are dealing with. So if you have facility for ECG, you should perform an ECG to see what rhythm these people are. Of course, once they reach to hospital, they will have further imaging like echocardiogram, and the diagnosis usually here we do cardiac MRI, because as far as I know, in Liverpool or Campbelltown, we haven't done any endomyocardial biopsy because it is too invasive. So we will diagnose this patient with the either echo or CMR. And then mainly the treatment, how you will treat. Of course, if they are asymptomatic and if there is a evidence of elevated troponin or elevated BNP where there is a myocardial injury, they will have more prone for arrhythmia. So they should be monitored till their the cardiac biomarkers are coming down and they become asymptomatic. Of course, if they have more than that, if they have evidence of heart failure, you may treat them with the dobutamine, some sympathetic mimetic drugs, and sometimes they may need some beta blockers, or if they have a conduction abnormality, you may have to put temporary pacemaker for these people. And obviously, if they very sick patient, they may need further management like VA ECMO, which just Shakthi told. And couple of days back, actually, we put in the Campbelltown, we had to put a ECMO on the patient and shifted him to St. Vincent because there was no bed in the Liverpool ICU. So we may have to do the ECMO. Some patient from literature, from veteran literature, they supported with the left ventricular assist device like Impella. We have a facility in Liverpool, but I never used on the COVID patient Impella. And so you can, if you're tied over the crisis, they usually do okay. And if you see the long-term prognosis wise, just Shakthi mentioned the key in these patients are early diagnosis and early management. And obviously, if you diagnose them early, you can give the interleukin 6 antagonists like Tosylusimab, or you can even try some the immunoglobulin to support this patient, which usually tide over the crisis. And once you're tied over the crisis, we don't know the long-term prognosis at the moment, whether they will have some arrhythmias, because again, it is too early to tell. And but historically, if you see all the myocarditis, if a patient present with any other viral myocarditis, 20% of them may go into the dilated cardiomyopathy. So the COVID may behave in the similar fashion. Then they will come back to you in the community with the heart failure features. They will be needing all the management like beta blockers, ACE inhibitors, and RAS inhibitors, all these medications to make them the LV function better, or they may end up with the cardiac transplant. Obviously, if a patient had the acute STEMI, which we do the primary angioplasty on these people now in Liverpool, and they again need antiplatelet therapy, and it is as just like any acute coronary syndrome patient, we have to treat them. So if a patient present early mild pericarditis or mild myocarditis or acute coronary syndrome where you can treat them, then the prognosis is probably not too bad and reasonable. Obviously, if they are very sick, we may lose the patient. And I don't have actually the exact data because we have only the evidence from the case series, like few hundred case series from few hospitals, and there is no real world data till to say what sort of prognosis we will have if cardiac involvement happens in the COVID. So this is a nutshell about myocarditis. Patient will have dyspnea, they may have chest tightness, they may be having any sort of arrhythmias like sinus tachycardia or conduction abnormality, and they may present with the cardiogenic shock or right heart failure. And you can manage them with doing the ECG or cardiac monitor. Cardiac enzyme is key because till the cardiac biomarkers come back to normal, you have to keep them in the hospital, or when till they become asymptomatic, you should keep them in the hospital. And you have to rule out other differential, like whether it is a acute coronary syndrome, or whether it is stress-induced cardiomyopathy, or it is just a myocarditis. And few things in the general practice also you may have to avoid in these patients are like the negatively inotropic drugs like beta blockers or calcium blockers. Avoid the NSAID. It will retain the sodium. It may worsen the heart failure, and also avoid the pro-arrhythmic drugs like the drugs which may cause the prolongation of the QTC, like all the antipsychotic drugs or the few antibiotics. They should be avoided in this situation. And another question probably you may come across is if a patient admitted with the myocarditis or the cardiomyopathy, he is discharged from the hospital, he will come back and say, when I can resume my normal activities. So if his cardiac biomarkers are normalized and he is feeling okay, then he should start his normal activities and build up his exercise capacity. And because they will be in the hospital, they already would have been deconditioned, so slowly get back into the life. Okay, that is the first part of my talk, and because of course we can talk hours together regarding the cardiac involvement, but the time limit, so I will move into the vaccine related myocarditis and pericarditis. As I mentioned, this the new infant born without any nappies, so they made a lot of mess with us, and now a couple of companies started making some nappies. Pfizer is producing some, Moderna is producing, as well as AstraZeneca. And of course, if they are safe, probably yes, there is very limited side effects, but we can see some clotting thing in the AstraZeneca, and you may see some cardiac involvement or inflammation of the heart muscles in the case of mRNA vaccine, either Pfizer or the Moderna, which we have recently acquired here. And what hypothesis put forward is it is hypersensitivity reaction to the vaccine, because it is uncommonly seen in the first dose, and usually it is the second dose, or if a person had COVID infection and if he receives the mRNA vaccine, they usually present with either pericarditis or myocarditis. And this is similar to the era before we born, probably, or when we are younger, the similar to the smallpox vaccine, which used to give similar hypersensitive pericarditis, I believe. And in mRNA vaccine, it is common in younger males rather than the females or older individuals. And usually it is seen the age group between the 16 to 29. And what figure they give is around 40 cases per million population in that. But if in the same population, if it is a female, then the incidence is only 5 per million. And if they are above 30, the incidence is around 2.5, and in female it is 1 per million. So it is very small amount of people will present with the eye inflammation of the heart muscle or pericardium. So how they will present? Usually this time course is first 24 hours to 5 days. They will have these symptoms in this time period. They may have chest pain, they may have palpitation, they may even have a syncope or dyspnea. I had few patients referred with these symptoms, and couple of them actually had a small amount of pericardial fluid, and probably they had a pericarditis, but rest of the people, I couldn't find any abnormality. They actually presented to emergency. Their cardiac biomarkers were negative. Their ECG was normal. So because of the awareness, these people may have probably overrepresents to us with these symptoms. And there is some guidelines, JAMA Cardiology put the how we will say these people have myocarditis following immunization. There are suspected, probable, or confirmed cases. So suspected, they will present you with the symptoms, dyspnea, palpitation, or chest pain, and they will have some abnormality in the ECG, like STT changes. There may be some atrial or ventricular arrhythmias. They may have a conduction abnormality, and Holter monitor may show again the frequent atrial or ventricular ectopics. And if they do the echocardiogram, there may be the LV dysfunction, or if it is a pericarditis, you may see a layer of pericardial fluid. And if more than that, like if they are probable cases, and same who meets the case of suspected criteria with the elevated cardiac biomarkers, if there is elevated troponin, that indicates a myocardial injury. So obviously they had myocarditis or a pericarditis, and then echo should show some evidence of LV dysfunction, and cardiac MRI usually clinch the diagnosis. And of course, if you do the endomyocardial biopsy, that is the confirmatory to see whether there is a inflammation of the heart muscle or not. But of course, no, I don't think anyone will do the endomyocardial biopsy just for the diagnosis sake. And so how, if a person present to you, what you will do, you do just clinical examination. You may have little tachycardia, and it may be sinus tachycardia, or you may see the irregular pulse if they have a lot of atrial or ventricular ectopics. And examination of the heart may give you some pericardial rub, but then you can say this patient has a pericarditis. And if you perform a 12-lead ECG, you will have, if there is a pericarditis, you will have diffuse ST elevation in most of the leads. Or if it is a myocarditis, you may have the inverted T wave or some ST depression. And obviously, cardiac biomarker like a troponin will be elevated, and do a chest X-ray, because if this patient present with the chest pain and shortness of breath, it may be just coincident with they may have some pulmonary embolism, which may cause these things, or they would have contracted some pneumonia that may be presented with the similar features. And so you have to do other tests like a D-dimer or CRP or full blood count to have other differential to rule out, because that may be just coincide that they had a vaccination and they got some infection or a PE along with that. So management, if there is a cardiac biomarker abnormality, or if ECG shows some changes, obviously they have to get admitted. But if ECG is normal, clinical examination is normal, and then you may able to treat them as an outpatient. And again, if they have a chest pain, I will not give NSAID. I will just treat with the symptomatically, like a simple analgesic like a paracetamol, or if you suspect a pericarditis, obviously you may have to put them on some colchicine. And they need, if there is any suspicion of pericarditis or myocarditis, they should have an echocardiogram and a 24 hours Holter monitor. And we usually manage them symptomatically, and all my patients till now recovered well. And even the literature wise, the adverse outcome is very, very small. There are few case reports where patient died because of some myocarditis and arrhythmias, but that incidence is very, very small. And this patient, if you suspect either myocarditis or pericarditis, you should advise them not to do heavy exercise till the symptoms were resolved and ECG normalized, and their cardiac biomarkers come back to normal, and the cardiac function also improved. And as I mentioned, our knowledge is still limited. Every day we get the new information regarding this disease. And if the patient had uncomplicated myocarditis or pericarditis because of the mRNA vaccine, you may have to have one follow-up in 12 months, or if they develop cardiomyopathy, they may need long-term follow-up. And another thing you may come across, because I get some calls from the GP, what to do with a patient of 20-year-old, 30-year-old patient comes with some history of heart problem, whether they can have Pfizer vaccine. And these are relative contraindication, not absolute. If they had a recent inflammatory cardiac illness, like if they had a pericarditis, myocarditis, or endocarditis less than 6 months, it is relatively contraindicated. Consult his cardiologist before giving Pfizer vaccine. If they have acute rheumatic fever, which we may not see here, but probably it is true for some other areas where rheumatic fever is common, then it is relatively contraindicated. And if a young patient who is known to have dilated cardiomyopathy less than 30-year-old, you should be careful. You should have consult their treating cardiologist, or if they are in the acute decompensated heart failure, again, you should be careful. And the patient who had a congenital complex heart disease, who had some procedure like a Fontana procedure or something, or a cardiac transplant patient, you should be careful considering the mRNA vaccine. I think that is finishing my talk. Hope I covered a little bit of both.
Hi, I don't know if you can hear me now. Sorry, I think I was still on mute. Thank you, Dr. Kishore. That was very informative and very comprehensive. Thank you. Thank you to all the speakers tonight who have contributed amazingly to improving our knowledge, increasing our knowledge in the GP field. We have gained a few different perspectives, right from the diagnosis all the way up to management and post-management. It does lead on to something I wanted to mention at the end of this topic, that on the 11th of October, we will be having another talk presented by another set of speakers. We're expanding on what we have started talking about today. That will include some more topics on the management of COVID, including long COVID and some psychological complications and implications of COVID-19. Thank you very much. Bertha, do we have questions? Do we have time for questions, or do we need to wrap up?
Yeah, we've got time for a couple of questions if there are any in the chat.
Okay. Thank you to those speakers who have been answering the questions live as we went along today. There weren't too many remaining. I just thought I'd touch upon probably one or two things. Dr. Tennant, if you'd like to give us a little bit of information about the new drug molnupiravir, please.
Hi, hopefully you can hear me. Look, there's been a significant quantity pre-purchased by the Australian government, but it's not yet TGA approved. It's a ribonucleoside analog, so it replaces cytidine and uridine in viral RNA, and it's an oral drug, which is obviously quite exciting because that's the first oral drug that we'll have against COVID. So Merck have released a press release of their Move Out trial, which was interim analysis. It was a phase 3 trial of non-hospitalized patients with mild to moderate disease. And they used a composite outcome of hospitalization and death out to day 29. And they found that those that were treated with the drug had, an outcome for that criteria of 7.3% compared to 14.1% of patients treated with placebo. So that was strongly statistically significant. And there were about 350 patients in each arm of that randomized controlled trial. That's all we know at the moment, but hopefully we'll get further information moving forward.
Thank you. Yeah, that's something for us in general practice to look forward to going forward as restrictions ease, and there will be quite possibly a lot more positive cases out in the community, but hopefully mild and moderate, that we can treat and prevent them from getting into hospital. With the Cetravamab, there was some concerns as to how we GPs can access it and be able to give it, given that it is an intravenous therapy. Of course, it would have implications to how we manage our treatment rooms and the administration in a COVID-safe way. Do you think that's about to come out soonish, or is it more of a watch this space? Any of the speakers, feel free to take that one.
It's Elaine Tennant. So as you say, it does require, a facility that's confident to manage an infusion. It's a 2-hour infusion, and there is a potential risk of infusion reactions. So certainly that's been seen in clinical trials, and I think, a very small rate of anaphylaxis. And of course, as the patient is COVID positive, and so you need to have really good infection control processes to be able to manage that. So I did post a link to the current ACI model of care for Cetravamab. My understanding is that it's currently being kind of allocated to LHDs. I know that there are some clinics. I believe there's one at Blacktown. There's definitely one at Prince of Wales. And I guess at the moment, all COVID patients are known to those, LHD-based community COVID teams. And so there are referrals coming through those pathways from those teams that are already on HIF and who've presented to hospital and happen to have the, the risk factors and meet the criteria. So we don't give it to patients that are vaccinated. It's only incompletely vaccinated patients that can have Cetravamab, and that's based on the group that were studied in the Comet ICE trial that's been talked about. But of course, this whole situation is very dynamic, so I think watch this space.
Yeah, thank you, Elaine. Just one question that was raised previously was about how soon after having COVID can someone undergo any other major surgery that they were perhaps scheduled to have electively. Shakthi, does it require a clearance from respiratory team if they were sick enough to be hospitalized and say in ICU and then recovered? Would they still have complications from getting an anesthetic and undergoing further surgery?
Yeah, it's a good question. I don't think we've got any specific sort of guidelines or policies that guide us in this sort of problem. Having said that, there was a study that looked at surgical complications, particularly anesthetic complications in patients with COVID, and found that if we delayed sort of elective surgery for at least 7 weeks, they had a reduced rate of mortality. But it also depends upon how urgently the surgery is indicated. So I don't think there's any sort of specific rules or guidelines. I would suggest that an anesthetics review would be quite necessary. And from a lung perspective, if they've still got respiratory symptoms, particularly dyspnea at rest or on exertion, that they could be referred for a respiratory physician, mainly to get lung function, to get an idea of what their lung function is, as that can also guide us as to any perioperative complication.
Okay, thank you, Shakthi. Thank you, everyone. I think we've answered most of the questions. There was just one more on if anyone could advise on the expected booster schedule for the vaccinations. I expect that is still a work in progress, but does anyone have any information on that?
I understand Ataji are making deliberations at the moment, and we might expect some news on that in the coming weeks.
Okay, beautiful. Thank you very much, Bertha. I think we're good.
Thank you very much, Dr. Vani, for organising all the speakers tonight, and thank you to all the speakers. Thank you, everybody, for attending, and we'll see you at the next session. Have a good night.
Thank you, everyone. Have a good night.